evening. Thank you for joining Continuous Learning with Bioguard. Let me share my screen. Okay. In today's lecture, we'll share clinical management of pyoderma in dogs. Since we have lots of information to share, so I won't. I'll skip the self-introduction part. Let's directly start from today. Before start today's lecture, same thing. I invite all of you following Bioguard's social media, like Facebook and LinkedIn. We share lots of knowledge-based information and product information in our social media. So please, if you haven't followed Bioguard, you are welcome to following Bioguard's social media. Speaking of canine pyoderma, pyoderma is actually very common disease in dogs. It's actually among the top 4 conditions leading to antimicrobial prescribing. The other 3 are urinary tract infections, respiratory tract infections, and gastrointestinal infection. And another significant concern is for the pyoderma is because of antimicrobial resistance in both humans and animals pathogens. They actually share the similar MRD. So today's lecture will classify the pyoderma based on histopathology depth of the infection. What does it mean by depth? It's actually based on the histological depth of the infection. So we classify them into 3: surface pyoderma, superficial pyoderma, and deep pyoderma. The advantage of this classification is because it's easier for us to check how we treat the dog with these 3 different pyoderma. You can see this figure. Let me use the. Sorry. Okay, I just forgot. So for surface pyoderma, we usually only require topical treatment. And if it's superficial pyoderma, commonly, topical antimicrobial therapy is also the first option, unless topical therapy failed or is not available, no option available. Otherwise, topical antimicrobial therapy is also the option for superficial pyoderma. The only exception is for deep pyoderma, because deep pyoderma usually require systemic antimicrobial therapy. So how do we classify them? Because the pyoderma, the basic differentiation is based on lesion type and location. And for surface pyoderma, it actually only involves the outermost skin layers. It commonly associated with hot spots or skin fold dermatitis. And for superficial pyoderma, it's extended into epidermis and hair follicles. And the typical sign including pustules, epidermal collarettes. And the last one, deep pyoderma, it involves the dermis and subcutaneous tissue. And the clinical sign including draining tracts, nodular, ulcer, and swelling. And this usually are more severe and require longer treatment. So this table just summarizes the three pyoderma and also the clinical presentation and the most common lesion and frequent clinical finding. It's just for your reference here. And the differentiation of pyoderma is actually quite challenging because the clinical signs often overlap between each other, and not all the pyoderma types are clearly defined. The example including the pyotraumatic dermatitis. This is a surface pyoderma, and versus pyotraumatic folliculitis. This is usually the deep pyoderma, and the overlap with other conditions like the lesion associated with deep fold, Intertrigo, this is the surface pyoderma, and the mucocutaneous pyoderma and mucocutaneous lupus erythematosus can closely resemble each other or overlap. So that's why we say the differentiation of this pyoderma sometimes is challenging. And for the bacterial pathogen involved in the canine pyoderma, it's usually the most predominant is the Staphylococci. That's the most common bacteria involved in the pyoderma. There are several retrospective Canadian studies performed between 1994 and 2013. They found the Staphylococci account for almost close to 80%, and then it's streptococci, and then Pseudomonas and E. coli. And among the Staphylococcus pseudointermedius is the most common one found in the canine pyoderma cases, and it may have the methicillin susceptibility or resistant to the methicillin. And for surface pyoderma, it have more mixed microbial population. It may have other Staphylococci, Enterococci, Streptococci, or gram-negative bacteria, and even the yeast. And for deep pyoderma, the Staphylococcus pseudointermedius remain the main pathogen, and others contribute to about 40% of cases. So for the deep pyoderma, bacterial culture and antimicrobial susceptibility testing are critical for treatment and management. And then let's check the diagnostic approaches to suspected pyoderma. The first thing need to do is always the skin examination, because skin is easily accessible for inspection and sampling. So it requires check the entire body for extent and distribution of the lesions. And it may be required to get rid of the hair and trim the long hair in affected area. Is necessary. And then the cytology, because cytology sample are the first access qualitative for the presence of the bacteria. Their morphology is calci or rocks, and for the presence of inflammatory cells. And sample from Staphylococci pyoderma lesion will typically show intracellular calci within the neutrophils. And this is the key tool for responsible antimicrobials stewardship. And the sensitivity for cytology is up to 93% in superficial pyoderma. Also, you can see the when we see the intracellular calci and the neutrophils, it's almost can say it has the superficial pyoderma. And the differentiate infection sometimes need to differentiate its infectious, or it's easy for us to differentiate its infectious or non-infectious through the cytology. And it's the best guideline for interpretation of culture and AST test. And then basically for the treatment is usually case by case because usually we need to confirm the bacterial cause before prescribing antimicrobial. That's just for if there's no clue, no evidence of the bacterial infection, we don't need to start with the topical antimicrobial therapy. However, if from the cytology we see the bacterial infection possibility, then topical antimicrobial therapy is necessary. And here are some example. Here are some example for the cytology. This one, the left, the upper left, label with A. You can see the calci. Most likely is the Staphylococci, some dividing into pairs, and quadruplet in and among the neutrophils. And the upper right with the B, you can see large number of calci without neutrophils from the dog with the bacterial overgrowth syndrome. And the bottom left can see large number of rocks among the degenerate neutrophils. This the impression smear of pus from a moist lesion on the neck. And the bottom right is the mixed microbiome morphology containing both rod and both rod and calci. And the diagnostic approach for the pyoderma, the investigation into the underlying primary cause is usually important because pyoderma is always secondary to an underlying cause. So the primary pyoderma is no longer tenable, and all the dogs are when we check the cytology, we need to know all dogs are colonized by Staphylococci, and the infection usually occurs when the skin barrier is compromised, and then the bacteria will embed through it and cause the secondary infection. And the common primary causes including the trauma, the ectoparasite infestation, atopic skin disease, and other systematic disease like endocrine issue, neoplasia, will also be the primary cause for this issue. And of course, there's also some clinical limitation because sometimes investigate and address, but keep in mind, always investigate and address the primary cause at the first occurrence. And the structural, immunological, or chemical change in skin may always just respond to the secondary pyoderma. This table just a typical underlying cause and commonly associated type of canine pyoderma, and it's also for your references. You can see maybe allergic issue, parasite issue, other infectious disease, endocrine, autoimmune issue. And so when we are trying to investigate the underlying primary cause, we usually need to check the cord brushing to see if there's fleas or severity there, and also check for the hair plugs, and skin scraping also important, and also need to confirm aqua right side or the insecticide prophylaxis is ongoing and appropriate. An additional diagnostic test may include dermatophytosis using the Woods lamp or do the fungal culture PCR. And for skin biopsies, check for histopathology because it's the best way to check if there's an immune-mediated issue or neoplastic conditions, and differentiate the nodular bacterial infections from the fungal protozoal granuloma, the sterile granulomatous disease, neoplasia, or foreign body reaction are also important. So the whole techniques to use, including the biopsy, spatial stance, moisturized tissue culture, and molecular methods. And also, sometimes the blood sampling for hematology, serum biochemistry, the endocrine test, and urinalysis, if the cause remain unclear, may also required, and may consider non-thyroid illness syndrome, complicated the lab results. So sometimes for the paired T4, free T4 with TSH for accurate thyroid diagnosis is also important because the thyroid hormone may also affect the skin's situation. And for the bacterial culture and the AST, antimicrobial susceptibility test, the law is to guide drug choice whenever systematic therapy is planned, especially for deep pyoderma. And this is preferred with the BC AST over the empirical treatment. And when there's an increased risk of antimicrobial resistance, like recent or frequent antimicrobial use, or previous isolation of MRSP, MRSA, MRSC, or the regions or the clinic with high prevalence of the methicillin resistance, at that time, the bacterial culture and AST test are highly recommended. And the best practice is always pair BCAST with cytology for correct interpretation. And of course, sometimes the cost can be a barrier. And the limitation for BC and AST is because the BC-AST test is not needed to diagnose the pyoderma. And sometimes, not sometimes, and the healthy skin sample may also yield bacteria because it's usually as part of normal microbiota on the skin. So sampling is quite important for the bacterial culture and AST test. And for empirical systematic antimicrobial, they are actually, as I know in lots of the clinic, it's quite frequently prescribed, and they are often effective and generally safe. And still, with BCAST based prescribing is preferable to reduce the treatment value and inappropriate antimicrobial use. And the strong recommendation for BCAST with cases with risk factors for the MRSP, if the patient already have a previous MRSP invasion or repeated antimicrobial, systematic antimicrobial causes, and frequent clinical visit, or have the referral hospital history. Because the NRSP prevalence is usually higher in referral centers. And here, this Bioguard just launched a mini AST in clinical mini AST system. It would be an easier option for the vets to use it in clinic because it can get a quick result, usually within 1 day. So the vets can make the treatment plan based on the test result. And the test result, some of the test result, like mini ST, will show you it's bacteria is susceptible, intermediate, or resistant to the specified antibiotics. Or if you send to the reference lab, some reference lab may provide the MIC value for the report. And since we just mentioned, because that's like a Staphylococci, actually a normal flora on the skin. So how to take representative skin sample actually quite important to for accurate BCST test and also for the cytology test. Type is moist or dry. Its depth or of infection and the purpose of collection. And for surface pyoderma, the most technique yield adequate diagnostic material. So for surface pyoderma, taking the sample is actually quite easy. And for superficial pyoderma, the best site for sampling is for the intact pustule or the skin beneath the crust or margin of epidermal collarettes. And the intact pustule are preferred because we can consistently harbor the same strain of Staphylococcus pseudodermitis, and the collarettes crust may contain multiple strains with different resistant profile. And for deep pyoderma, we can collect from the exudative lesions like fresh pus, draining sinuses, fistula, and pustular contents. And we need to remove the superficial debris before sampling. If the infection is below the surface, interdigital nodules, acrylic dermatitis, then obtain tissue biopsy under aspect conditions. And if the biopsy not possible, then can use the fine needle aspiration. And the surface swab are unreliable. So for the deep pyoderma, better to collect from the exudative lesions. And for the cytology, the acetate tape and impression smear are good for the bacteria. Smears better for neutrophils. And swab aspirate can submit in transport medium or using the cotton swab. And for draining nodular lesions, when we collecting them, I need to wear the gloves to keep this stereo and request it. You may request the lab for extended culture for the anaerobia and fastidious bacteria or even the fungi. This table just summarizes for different lesion type and for cytology, how to collect it for cytology purpose, how to collect the sample for cytology test. And for bacterial, the last one is for the bacterial culture, how to collect the sample from these different lesions for the bacterial culture purpose. And this is also for your references. And then let's check for the surface pyoderma. The surface pyoderma is including the pyotraumatic dermatitis, the so-called hotspot. It's usually rapid onset, often within hours. It can it's, have the agitative, localized, painful, or pruritic lesion, and it's usually caused by self-trauma triggered by itch, discomfort, or pain. Like the figure on the top, that's the pyotraumatic dermatitis. And the second one is the intertrigo, or it usually occurs in skin fold, like the figure in the middle. And you can see the moisture and secretion promote microbial dysbiosis. This involves both bacteria and the yeast. And the third one is the bacterial overgrowth syndrome, like the bottom figure. This usually presented with non-specific lesion. And you may see the erythema, hyperpigmentation, and lichenification. And the cytology for this usually show large number of bacteria, but few or no neutrophil or macrophages. This usually considered dysbiosis, not a true infections. So we won't see the pus or the inflammation. And just another reminder, for all the surface pyodermas, they are secondary to the inflammatory infection. And the microbiome study show the Staphylococcus pseudodermatitis overgrowth and reduced microbiome diversity. That's what they found from the from the surface pyoderma. And for diagnosis of the surface pyoderma, it usually based on the compatible history and suggestive lesion in the typical location, and the cytology can confirm the bacterial involvement and guide the topical therapy choice. And for the BCAST, usually not required because it's only for the topical treatment. And for topical treatment, usually no need for bacterial culture or the AST test. And then we also need to find out the underlying primary disease if we want to. That's the key for long-term treatment success. And for the differentiation challenge of the surface pyoderma diagnosis, including the pyotraumatic dermatitis versus pyotraumatic folliculitis, because this one is happen in deep pyoderma. So the lesion can look similar clinically and histopathologically. So hair clipping and careful exam needed to rule out the deep pyoderma. And satellite lesions like pustules, hemorrhagic crust, swelling, those also suggest deep pyoderma with heterogeneous spread. And also for Intertrigo may resemble the mucocutaneous pyoderma. And for once we confirm the surface pyoderma issue, the topical therapy is preferred for the surface pyoderma, and systemic antimicrobial should be avoided. And the effectiveness of topical therapy alone is actually equivalent to systemic therapy in pyotraumatic dermatitis, bacterial overgrowth syndrome, and Intertrigo. And so antiseptics like chlorhexidine is usually the first choice because the antiseptics have broad activity against most skin pathogens and can be chosen empirically. And for topical antibiotics, we use it only if needed. The selection would be based on the cytology results. So if on the cytology we observe the bacteria, like in the neutrophils or outside the neutrophils, and with the suggestion of bacterial infection, then the topical antibiotics can be prescribed. And for different lesions, we may need to use different type of the drug. Like if for the pyotraumatic dermatitis, it's usually localized, so can use gel or spray. And for Intertrigo, it's usually occurs in skin folder, so using wipes or gels for deeper penetration purpose. And for widespread lesions, then shampoo or spray would be a better option. And sometimes the supportive cares like analgesia may be required, especially for painful pyotraumatic dermatitis lesion to facilitate the topical therapy. And sometimes we may use combination therapy, including both topical antimicrobials and topical glucocorticoids, or can use the short course of systemic glucocorticoids at anti-inflammatory doses. And also antipruritic medication may be added, and this will especially helpful in pyotraumatic dermatitis, and like Intertrigo with inflammatory case also would be good for the antipruritic medication. And since the inflammation may play a major role in surface pyoderma, so anti-inflammatory treatment is also widely accepted. And after the treatment start, the clinical resolution usually the definition would be the significant improvement or resolution of pre-treatment lesions, like normal cytology from the previous affected areas. And this is expected within 7 to 14 days. And then for the follow-up, the veterinary reassessment is recommended if poor progress reported. And in this case, repeat cytology is required to confirm the resolution. And also need to review owner compliance and diagnosis of underlying primary causes. And speaking of the long-term management of the surface pyoderma, the continued antiseptic treatment on previous affected skin makes potentially lifelong, and especially important when the primary causes cannot be resolved. And this can help reduce the risk of recurrence. And if the recurrence occurs, it will be common if the primary causes remain uh, elusive or uncorrected. And some special management like weight loss or surgical correction of skin fold may help in intertrigo situation. And for the chlorhexidine use is like usually the first option because this have been used for decades and no true resistance have been reported. So there are some in vitro tolerance declared, but the clinical concentration far exceeds the MICs. So far, no evidence of the treatment failure due to the resistance to chlorhexidine. An additional preventive option may include if this allergic causes suspected, can consider proactive topical anti-inflammatory therapy. And here's some approach for the pyotraumatic dermatitis. So the initial care would be handle lesion carefully because it's often painful and may consider systemic or local analgesia. And for local management, I need to clip hair around the lesion and surrounding area. After that, we need to clean to remove the debris and biofilms. And then, also, by the way, the biofilm is actually the bacteria. After bacteria grow, it will form a thin layer on the top of the supporting material. And once the biofilm form, uh, it will affect the treatment because within the biofilm, the bacteria is highly resistant to the treatment. So remove the debris and biofilms are important for the treatment. And then can apply antiseptic or topical antibiotics and can optionally combine with topical glucocorticoid. This may require once or twice per day for 7 days. And then another is the anti-inflammatory therapy. You can consider short course for 5 to 7 days using the prednisolone, dexamethasone, or JAK inhibitor. The goal is to reduce the inflammation, pain, and itching. And then, of course, investigate underlying causes are important. It's important. So, may need to review the actual parasite prophylaxis and check the ears and anal sac and consider underlying allergic disease. And for approaches to intertrigo, for local care would be like clean affected skin remove the debris and biofilm, and then after that, apply antiseptic therapy. And then also for the cytology guided therapy, because if we found the bacteria in the in the cytology examination, like a RAS dominant, then may need to add some gram-negative coverage, like a silver sulfadizine or gentamicin cream drops. And for facial dermatitis near ears, they use the ophthalmic safe formulation, like the fusidic acid eye drop or gentamicin eye drops. And for the anti-inflammation support, like for severe erythema, swelling, pain, can consider topical antimicrobials combined with glucocorticoids. And for special consideration, like if the erosions, ulcers present, may use the hypochlorous acid products until healed. And there's also an option of surgical in refractory cases, like for lip fall, for ingrown tail, or for the barboplasty. So after the surface pyoderma, then let's check the superficial pyoderma. Because the superficial pyoderma is the bacterial infection affecting the epidermis and hair follicle. So far, there are 4 clinical presentations described. The most common one is the superficial bacterial folliculitis. The left figure is the superficial bacterial folliculitis affected by the inguinal region of a golden retriever. And the right side is on the trunk and the lateral side of an American Pit Bull Terrier. So first, let's check the superficial bacterial folliculitis. The pathogen is usually the Staphylococcus pseudotremendous, and it's usually often the pure culture. This is the most common pathogen called the SBF. It can be linked to the absence of sebum plug at the follicle opening, and other anatomic or physiological factors may also be suspected. And with the formal lesion, and the progression would be from the erythematous follicular papules that become pustule, then become epidermal collarettes, and become the focal apropecia. And the distribution would be most common in median and long-coated breeds in their ventral abdomen and medial thigh. And for short-hair breeds, it's usually in truncal apropecia and moth-eaten appearance. And other signs would include tufts of hair elevated, scaling, dark coat, increased shading, milder and breed-specific, especially for American Cocker Spaniel, which show hyperkeratic plaque-like crust. And for post-inflammatory hyperpigmentation, is common, may persist even after the disease resolution. And then another one is as for the active superficial pyoderma. This the previous name is the superficial spreading pyoderma. Right now, they are called as for the active superficial pyoderma. You can see this figure, the disease on the clean dorsum of a dog. The lesion is characterized by large epidermal collarette with erythema, small multifocal erosions, and peripheral exfoliation. And it has some predisposition, especially in Shetland sheepdog, Australian Shepherd, and German Shepherd, and also Collie breed. And other breeds and mixture breeds can also be affected. And this figure is also an active superficial pyoderma in a Shetland sheepdog. And from the histopathology, it's actually can distinct from the superficial bacterial folliculitis because it's usually frequent intracorneal cracks may contain basophilic cellular debris and bacterial cocci. And it also has some variants, like a less common form in generalized erythema and large sheet of scale. And then let's check the impetigo. Impetigo in juvenile dog is often visually distinctive from the SPF. The visual have the impetigo include large pustule. Okay, you can see the figure here, and non-follicle orientation and absence of erythematous pustule. Suggested risk factors for this impetigo, including poor nutrition, endoparasitism, and concurrent viral infection. And for adult dogs, impetigo usually occurs in immunocompromised dogs, and the feature including large non-follicular pustule and bullae in glabrous areas. It may associate with some spontaneous hyperhidrosis, cortication. And the figure here, you can see it's the this is a mucocutaneous pyoderma of eyelid margin and medial casus in soft-coated Wheaton Terrier. And because when compared to human impetigo, the impetigo in dogs is not highly contagious, usually linked to immune status and local factors. And however, in human, it's this impetigo is usually highly contagious, caused by as for detective toxin-producing Staphylococci or group A streptococci. So it's different between humans and dogs. And for mucocutaneous pyoderma, that's the figure we see on previous page. The lesion will include erythema, erosion, ulcers, crust, pigmentary change, usually occurs at mucocutaneous site. It can resolve with antimicrobial treatment. And microbes not well documented for this pyoderma. It likely involves skin microflora and Pseudomonas spp. And the differentiation diagnosis would for perioral and perivalvular lesion may mimic Intertrigo. So it must also be differentiated from the mucocutaneous lupus erythematosus. And for the clinical notes, like it will include as the superficial pyoderma in Canine when lesions resemble Intertrigo but are more severe. And for predisposition include the German Shepherd dogs. And if the lesion persists after infection, dysbiosis treatment, then biopsy and histopathology may be required for advanced diagnosis. So for the super pyoderma diagnosis, usually require clinical sign with the cytology. And in cytology, may observe the causa with also the neutral fields. And we need to exclude other follicular disease like dermatitis. It can do and can check through hair plugs, deep skin scrapings. And for dermatitis, can using the Wood lab direct hair exam, fungal culture, and PCR. And for pemphigus, for the axis can mimic SPF, so the lesion may be in a typical site. And the cytology, we see the acantholytic keratinocyte with neutral field, eosinophils, and few or no bacteria. And we can consider biopsy if lesion persists after the treatment because it may immune-mediated partial disease or leishmaniosis. So for diagnosis of superficial pyoderma would be the as for the active superficial pyoderma is usually large. It's pencil epidermal collarettes, and it can be confirmed by cytology. And we need to exclude the dermatitis and dermatophytosis. And histopathology usually not required. And for impetigo, the juvenile dogs, the diagnosis can based on signalment, interfollicular posture, and cytology. In rare cases, may require histopathology to differentiate from pemphigus folliculosis And cytology can see mild or absence of cystitis. And for mucocutaneous pyoderma, the clinical diagnosis would be lesion at the mucocutaneous junction and plus the cytology. And we can confirm by resolution with antimicrobial therapy. And for differentiate from Intertrigo and mucocutaneous lupus erythematous is important for this pyoderma. If the lesion persists after invasion, this biopsy treatment, then biopsy and histopathology may be required for more advanced diagnosis. And for topical antimicrobial therapy of the superficial pyoderma, the sole antibacterial treatment for this SPF is the treatment of the option. And from 12 published clinical trial, they already find active ingredient with proven efficiency, including the 2 to 4 chlorhexidine products and 2.5% benzoyl peroxide shampoo and sodium hypochlorite carbonated water polyherbal preparations. And when compared with systematic therapy, in a randomized clinical study, when compare 4% chlorhexidine shampoo with solution versus amoxicillin clavulanate, the results show equal effective for both treatment after 4 weeks. So that's why usually we say topical option. Topical treatment is the first option. And for the clinical implication, like a topical therapy should be prioritized and with wide availability of effective formulation. And this can support antimicrobial stewardship by avoiding systemic use. And here's the approach to SPF. First, for the local and widespread lesion, for widespread lesion, can use the chlorhexidine shampoo 2 to 3 times per week and 10 to 15 minute contact time rinse. For localized lesion, same thing. Can use the 2 to 4% chlorhexidine wipe spray or foam once daily. And for supportive measures, can clip the affected areas in long-coated or plush-coated dogs and ensure adequate ectoparasite prophylaxis. And for monitoring the treatment, we usually need to reassess after 2 to 3 weeks. And if the progress satisfactory, can continue antiseptics until all lesion resolve and underlying primary causes identified and corrected. And if the progress is poor, then need to review owner compliance, review product used, investigate primary underlying disease, and may need to consider systemic therapy. And for the response to the topical therapy, the reassessment, you just say the veterinary check after 2 to 3 weeks of the topical therapy. And for clinical trials, the lesion, in the clinical trial, they already find the lesion improvement usually occurs within 1 to 2 weeks of the therapy, and the resolution occurs 3 to 4 weeks after the therapy. And we can continue the topical antiseptics until all the lesions resolve and underlying primary causes identified and corrected. And if systemic antimicrobial therapy is needed, that's when the topical therapy not visible due to dog's temperament, owner's ability or compliance, and available facility, or the poor response after 2 weeks of topical therapy alone, then the systemic antimicrobial should be reserved for cases for failing topical therapy and cases where topical therapy is not possible. And the principle of systemic antimicrobial therapy, we mentioned bacterial culture and antimicrobial susceptibility testing, and also cytology should guide the drug choice whenever possible, because empirical selection only if risk of methicillin resistance is low. And in this case, use first choice agent only. And for first choice agent, usually including clindamycin, cephalaxin, cephalosporin, amoxicillin, clavulanate. And for the rationale, like in vitro and in vivo study, the first choice agent is effective against most methicillin susceptible Staphylococcus pseudotermedius. So, and the minor susceptibility variation may exist, and still BCAST always can justify the issue. So, if really need a systemic antimicrobial therapy, always should do the BC and AST, also the cytology first. And the BC-AST is particularly variable in areas with high prevalence of MRS. And it's prevalent. We should prevent expense from ineffective treatment. And for clinical suggestion, is systemic drug should never be chosen empirically unless condition above are met. And the BCST remain the gold standard for tailoring therapy to the individual dogs. And for systemic antimicrobial therapy duration, it usually require 2 weeks, 2 weeks of the course, and then need to schedule the re-examination before end of course, and then based on the re-examination to decide to stop or extend the treatment.
Okay.
And there are some study already show for substantial proportion of dog usually cured at 2 weeks, and the improvement typically begin within 5 to 7 days. And in some US FDA approved field trial, cefovecin have 94.8% cure in the case at 14 days, and for cefotraxone it's around 91.2% cured at 14 days. So it's actually quite high. So that's why systemic antimicrobial usually require BCAST first to prevent the AMR occurs. So for the therapy, systemic antimicrobial therapy duration, previous usually is 3 to 4 weeks. Right now, the current recommendation is that initially give a 2-week course and then with the re-examination, and extension only if the lesion not resolved or the underlying disease persists. And if re-examination not visible, then may need to extend treatment cautiously. A more complicated chronic case or MRS infection may require longer therapy, and avoid just in case prolonged prescription. Instead, use frequent monitoring. And also need to recognize the inflammation may persist after infection resolution. So the cytology should guide the decision to start antimicrobials. And for adjunctive topical antimicrobial therapy, we may shorten systemic treatment duration, provide the evidence from the studies. You can see the cefalexin combined with acyl lactate basin for 14 days. This can lower severity index versus systemic therapy alone. And some other study show below. So the adjunctive topical therapy combined with the systemic treatment can definitely shorten the treatment course. And so when should we stop systemic therapy? Is when the primary lesions are no longer present, and the cytology from here skin, like see many squamous culture may still yield normal flora, and persistent sign may reflect underlying causes or secondary lesions, not actually the active invasion. And for topical therapy, this antiseptic treatment can be continued longer than systemic therapy, potentially lifelong if primary cause cannot be resolved and recurrent risk remains. And for mucocutaneous pyoderma, the topical antimicrobial therapy alone for most cases is the choice, and the preferred formulation include gel, ointment, or cream. And if there's extensive ulceration and pain, then need to consider systemic therapy. For cases that fail to respond to topical therapy alone. And for the systemic therapy, it always based drug selection on the BCAST test, because pathogen may be diverse with variable susceptibility. And for topical therapy, it's usually sufficient and minimize systemic antimicrobial use. And for systemic therapy, usually reserved for severe or refractory cases. And BCAST test ensure targeted, effective treatment and reduce risk of resistance. That's some approaches to mucocutaneous pyoderma, like initially treat invasion topically and guided by cytology and prioritize gel, ointment, or cream formulation. And if erosion also present, then consider hypochlorous acid products. And then reassess after 2 to 3 weeks. Evaluate the lesion resolution. If the lesion persists, and also cytology show invasion, may consider systemic antimicrobial therapy. The systemic drug choice must be guided by BCAST. And if the infection clear but lesion remain, may consider biopsy and histopathology to rule out. I also need to rule out the leishmaniasis, discoid lupus erythematosus, and mucocutaneous lupus erythematosus. And for underlying causes, we still need to investigate, correct, or manage primary causes. And if it's chronic or relapsing cases, may need to consider proactive therapy, like a daily 2 to 4% chlorhexidine wipes. And long-term topical management may be required. And then let's check the deep pyoderma. For deep pyoderma, the bacterial invasion of the dermis is usually the bacterial invasion of the dermis, sometimes extended into the subcutaneous tissue, can be widespread or localized. And if it's localized form, often named by the site, like acrylic dermatitis. And it's usually the clinical significance of deep pyoderma is because they are usually proximity to dermal blood vessel with risk of hemoteneous spread and sepsemia. Cellulitis is usually with diffuse inflammation and usually very painful, often no self-trauma. And for acrylic dermatitis, you may see the intense self-trauma due to irritation, discomfort. And the severe case may heal with scarring. And for skin lesion, may see hemorrhagic crust and hemopurulent discharge. That's the evidence of infection in dermis. And for rankles, may see the ruptured infected hair follicles greater than 3 millimeter, red bluish pustules, and carbonal. It's the infections spanning adjacent follicle, and nodules, ulcers, and necrosis. That's the lesion. And for pathogenesis, you may see the extension of bacterial folliculitis to become become furunculosis. It's localized lesion with the trauma. And the disease causes may depends on the host immune response. It may spread along tissue plane and with gradual or explosive. The explosive spread typical with beta hemolytic Streptococcus canis. And if we check histopathology, can see the neutrophilic or pyogranulomatous in, uh, infiltrate focus around follicle at the nexa. And this figure, these are some figure for the deep pyoderma. For the upper left is the chin pyoderma, and upper right is the interdigital lymphatic nodule, and then bottom left is the acrylic dermatitis, and bottom right is the widespread deep folliculitis and furunculosis. And for diagnosis of deep pyoderma, the compatible lesions include the draining tract, hemorrhagic tracts, purple papular, ulceration, swelling, and the cytology is good for confirmed bacterial cause, like can see the pus, cocci, neutrophils, and need to clip long matted hair to appreciate lesion. And in some cases, the acrylic dermatitis, the bacterial sign is less obvious, so the diagnosis is based on suspicion. And invasive sampling may be required for biopsy or needle aspiration. And the underlying primary cause may include atopic disease. That's the most common cause. And dermatitis, hyperthyroidism, hyperadrenocorticism, and necropsy process. And also, environment may also play a role, especially important in acrylic dermatitis, callus pyoderma, interdigital lymphatic nodules. And BCSC is definitely important for deep pyoderma before the treatment. About 60% of isolate would be the Staphylococcus pseudotermedius. And if you still remember, in superficial, more than 90% would be the Staphylococcus pseudotermedius. And the gram-negative organism like E. coli, Pseudomonas may also be observed, and mixed infections are also common. And anaerobic pathogen is rare, but anaerobic culture should be considered when you send in the sample to the lab. And because it's with greater pathogen diversity, it will impact drug choice. So that's why BCST is important for the deep pyoderma. And the best practice would be submit sample to lab or following the recognized standard. Ensure sample are representative of deep infection, and always perform cytology from the same lesion. Or you can choose the Bioguard in clinic mini AST. And then the timing of the therapy because for deep pyoderma usually require systemic treatment, anti-treatment. So it's best to start systemic antimicrobial after BCST result available. And if risk of deterioration or sepsemina exists, then can start the empirical therapy guided by cytology. Then adjust once the lab result received. Or you can consider the in-clinical mini-ST because in this system you can get a result usually within 1 day and get a suggestion of the whether the bacteria is susceptible, intermediate, or resistant to the specific antibiotics, which is better. You can make the treatment plan for this patient. And then for drug selection, usually if we based on the AST result, just choose the antibiotics based on the AST result and first choose the first choice drug like we mentioned previously, the clindamycin, amoxicillin, some in previous page. And for adjunctive topical therapy, recommended in every case once dog is pain-free because the benefit it can remove crust, reduce microbial load, decrease pathogens, may shorten systemic therapy duration. And once the treatment start, it usually requires 3 weeks systemic antimicrobial course, then re-examination before the end of course, and based on the checkup to decide to stop or extend treatment. If the signs improve but unresolved, then and also the cytology show infection, then need to continue therapy and then do the re-evaluation every 2 weeks. And stop the systemic antimicrobial when lesion resolved or no cytologic evidence of infection. And if the progress pressures, then confirm bacterial nature with cytology. Or if the bacteria present, then repeat bacterial culture AST to check for resistance. If no bacteria, then can consider sterile disease process or underlying primary causes. And also the adjunctive therapy, the topical antiseptic can continue beyond systemic therapy, and it may be lifelong if primary causes cannot resolve. And for the deep, the treatment for deep pyoderma with systemic antimicrobial treatment usually may require 4 to 12 weeks, sometimes 2 weeks beyond cure. Current would suggest do the 3 weeks of initial courses plus 2 weeks recheck. And right now it's actually rarely greater than 6 weeks required for secondary pyoderma reservation. And if the chronic lesion may heal with scarring, alopecia, and then the antimicrobial not needed if the inflammation persists without bacteria, then consider anti-inflammatory therapy. The frequent re-examination allow adjusting the therapy and monitoring the compliance and investigating the underlying causes. And for pain relief may be required if the dog is likely to be in pain. And for the underlying primary cause is actually required, actually need to be addressed because it's essential for resolution and prevention of recurrence. And for adjunctive therapy like fluorescence biomodulation can shorten times to lesion resolution in deep pyoderma. And for reported resolution of NTR pyoderma, it already have been reported in 16 dogs with the fluorescence biomodulation therapy. And for tolerated management, need to be adjusted based on the disease presentation, underlying primary cause, and body site affected, and owner practicality. That's the treatment approach for the deep bacterial folliculitis. So initially, use a 3-week systemic antimicrobial therapy. Select the antibiotics based on BCAST result and prioritize first choice drug. And if susceptible, and add adjunctive topical antimicrobials like previous described, and apply every 24 to 48 hours. And also, if the dog is in pain, may need to provide pain relief. And for underlying causes, we need to identify and manage the primary causes, and also ensure long-term plan for correction management before starting the topical therapy. And then we need to do the re-examination before end of the first 3-week treatment course. If all lesion resolve, then stop systemic antimicrobial. And if the lesion improving but pyoderma remains, then continue antimicrobial for another 2 weeks, and can schedule re-examination before end of the extended courses. And this need to be repeated every 2 weeks until resolution. And if lesion pressure or worsen, then reassess compliance. And for adjunctive or alternative therapy, can consider anti-inflammatory drugs and can continue topical antiseptic long-term if recurrence risk. For the antimicrobial stewardship, this because the skin is easily accessible, and it's quite unique opportunity for sampling and topical therapy. So it's a good choice for the antimicrobial stewardship to prevent the AMR spreading. And the routine use of cytology for checking topical antimicrobial and correction of underlying primary causes are important. And this measures substantially reduce reliance on systemic antimicrobial. And for systemic antimicrobial therapy, and needed only in selected cases, especially in, as I know, for deep pyoderma is definitely required, but for the surface and superficial pyoderma, they may not require the systemic antimicrobial therapy. And can provide evidence-based recommendation for reasonable drug choice and use. And of course, this also depends on the area, because you may have some in your area may have a different regulation, and some antibiotic may be not available in your area, or in your area maybe have some high prevalence of MRD. So this will be area by area. And the adherence of this can increase successful treatment outcome and reduce risk of inappropriate sedation pressure on pathogen commensals. And so that's it for today's lecture. And by the way, if you would like the PPT, just leave the link and email. We'll send you this after the webinar. And we also issue the e-certificate if you participate more than 15 minutes in this webinar, and we'll send it to you through the email. Okay, if no more questions, we'll call the end of the day. And thank you for participant. And we hope to see you again in our next webinar. Thank you and good night.